I don't normally do this, but I just wanted to say, thank you for inviting me here, but also I think this is an outstandingly well run conference, so congratulations on that. I would like to set a little bit of context for the work that we have done, because I think if you've come here to hear about a method that allows people to pay more for individual therapeutics, you're going to be a little bit disappointed, I think, because that's not the aim of the exercise in terms of what we're trying to do. What we're trying to do is to provide an evidence framework that allows decision makers to enable the kind of work that you've seen in the last 3 presentations. The cell and gene therapy Catapult is totally focused on cell and gene therapy, and cell and gene therapy is a disruptive technology. And it became apparent very early on in our work that there are 4 things that needed to happen for this technology to reach patients in high volumes. Firstly, there needed to be a lot more therapeutics coming through, so government needed to invest much more in research. Secondly, the cost of goods needs to come down very, very dramatically, which meant there needs to be investment in manufacturing technologies. Thirdly, there needed to be the capacity to deliver at volumes, which meant that there had to be investment in manufacturing capability and capacity. And fourthly, there needed to be much greater uptake within the system in order for patients to receive the therapeutics. All of those speak to investment and to system change. And as we were going around talking to institutions like the ones you just heard about, it was very clear that people in those institutions knew what they needed to do. We always get talked to about the cell and gene therapy Catapult about the failings of the HTA exercise or HST exercise. And actually, we don't subscribe to that. We subscribe to the principle that if you want the sort of systematic change that we've been talking about this morning, that will enable much greater volumes of therapeutics to reach patients, that has to have political support. And in order for there to be political support, there needed to be evidence. So as we went round telling the story of what needed to happen in order to introduce more cell and gene therapies into the system, people would say, politicians in particular, as we talked to them, say, great, we buy it. Absolutely, this sounds brilliant. Show us the data. So then the question becomes, how do you get to the data? Because we couldn't find it. So we set out from scratch to say, how would we produce information that would allow policymakers to support the work that we're doing? And rare disease is obviously a very close cousin of cell and gene therapy in terms of its needs and its dynamics. I think I've talked through much of this. It's necessary because these therapeutics do not fit the system. In terms of their cost, in terms of the way that they operate, very often it's a single application up front and a long tail of data and information that comes later. And it's quite hard to stop the therapeutic when it's a single application, et cetera, et cetera. But the key to change was getting support from the Treasury. Why was this necessary now? Because there is this wave of new technologies coming through, and many of them have this same disruptive profile in that they are aiming to be disease-modifying as opposed to symptomatic treatments. Secondly, the information revolution has a big effect on the way that healthcare will be run. I'm not going to talk about AI. I'm not going to talk about the work that Mel is doing. She'll talk later on. But the point being, the more data you have and the more you're able to analyze it, the more you granularize your activities, which means that the payment systems that, as Jack was referring to earlier on, are not set up for granularized decision-making. They're set up for cohort-based decision-making. So you need changes to the system in order to enable this. Thirdly, as we've heard already today, we're in an age of enlightenment from a regulatory point of view. And so people can't hide behind the regulator anymore. Change can happen. The sorts of things we want to happen can take place and will take place. And also, as we've heard from Kath earlier on, there is a government imperative to try and make these changes. But the other point to remember is this is not a UK thing. this is happening across the world. But the UK is slightly ahead right now, and we have the opportunity to keep that pace and move forwards and demonstrate to the world our leadership in this space. So what did we do? We basically went back to Treasury Green Book and said, how do they analyze technological change or investment? And we tried to create a method that would be repeatable and reusable in terms of looking at the changes to the system that will be necessary in order to enable technological adoption. We made the rule that it had to use data that was available today. That may seem obvious, but without data, it's not going to get support. It does reveal in the process other places where you might want to find data, but it had to work off today's data. And then we had to look beyond the healthcare system. So an HTA will capture most of the value of the healthcare system. But beyond that, in terms of how does the development of a new industry in the UK, how do you get the benefits of that for society as a whole? And it operates at the therapeutic class level in terms of introduction of new groups of technology. One of the abiding themes of the whole of this exercise is that the way that our current systems work with respect to adoption of new technologies is that they slow down volume adoption. And volume drives the economics of therapeutics, particularly in the cell and gene therapy space, massively. It will also drive the economics, this may seem paradoxical, but it will drive the economics of rare disease treatments as well. So the more you can think about the way that you enable volumes and things like that. For example, I mean, if you use platforms in rare disease, you enable aggregation and the economics of volume. We devised a method, it's not a new method, but it was an application method. Transition state model roughly basically says you look at the disease areas and you say, what are the key groupings within those disease states? The simplest form would be well, sick, dead, but in between there may be various different states. You gather data associated with those states. You say, if you apply these therapeutics to those states, how do the numbers in each of those groups change? And what is the reduced economic burden as a result of those changes? Two key parameters to understand in this model. One is it uses the Treasury's £70,000 threshold level as opposed to the threshold levels that are used by NICE. And the second is it uses the Treasury's 10-year horizon, which is phenomenally conservative because, for example, if you treat somebody today, you can take into account 10 years worth of benefits. If you treat somebody in year 9, you would only take into account 1 year's worth of benefits in your analysis. So it is quite a conservative model, which kind of works in its favor if you get the right answer. We then looked at it at various different levels in terms of the individual, the system, and the nation as a whole. Now, unfortunately, this is a busy slide, and I don't want to dwell on it too much, but I just want to illustrate in the next couple of slides the principles of the outputs so far. The way that we applied it is we took 4 different disease areas, deliberately selected to be different. So there's a pediatric, there's an elderly disease area, there is a working population disease area, carer burden disease area. And we ran them through the model to see what the outputs were. The headline of this is, using this Treasury-based economic model, is that there is as much economic value for the nation as a whole as there is in the healthcare-related side of the economics. In other words, there's a lot of money left on the table from an economic growth perspective by not adopting, in this case, cell and gene therapies, but the same principle would apply to systematic change in rare disease. There is some granularity to that it's worth understanding if you're going to go forward and use it further. So, and I'll just touch on this very briefly. Firstly, if you treat a child, say 4, with a 10-year time horizon, the economic benefit you get from them entering the workforce doesn't get picked up by this model. So that's something that we need to work on. If you treat diseases in the elderly, there's a huge amount of healthcare benefit, but the economic benefits are limited. Obviously, thankfully, treating diseases in the working population has a high benefit. Treating diseases with carer burden has a high benefit. And treating diseases with high prevalence has a high benefit. All intuitive things, thankfully, but also they support the generation of data and they support the model whose primary purpose is to get decision makers to support the kind of changes that we are making. So implications, there's money left on the table for government, and there's a good reason to intervene. There's money on the left on the table for industry, and there's a good reason to work with government in order to bring about change. It's not an argument for a higher price. And there is some work to be done in terms of the structure of the analysis. So where are we going with this? We're validating it and building it out with respect to other disease areas to see if that changes. We haven't seen much so far in terms of the basic parameters. We're trying to extrapolate it out now within the cell and gene therapy sector to say, okay, if you look at the pipeline of things that are coming through, if you applied all of those systematically and you got the kind of volumes from widespread adoption, and the benefits to patients from widespread adoption, what would that mean in terms of total economic benefit? We're also trying to estimate the value of development of an industry beyond that, which is incredibly difficult to do. And then looking at what does it take to make that change? What are the costs of making that change? And working with experts to determine the kind of, essentially a cost-benefit ratio coming out of this in terms of if this is the total benefit, this is what it's going to cost. How does that stack up against Treasury-based decision-making? Preliminary indications, and I can't release anything because I haven't published anything, but it looks very, very favorable, as you would hope. Okay, so I'll just conclude from my perspective. There is a lot of money left on the table from an economic perspective. We can see where that value is. There is a good incentive for government to change, to enable change. And remember where I started, which was we have, I think, some fantastic agencies in the UK who are very, very keen to make change, but they need air cover. They need the political support to say, yes, we really want to do this because we believe and we have evidence that making these changes is going to be economically beneficial for the nation, and therefore we can invest the nation's money in it. And I believe that we now have a mechanism that enables that conversation to take place, and that the timing is probably the best timing I've seen in my lifetime in terms of the things that we saw earlier on, in terms of data, in terms of regulators, in terms of international competition. And I'll pause there. Thank you very much.
That's wonderful. Thank you very much, Matthew. And really helped reframe the conversation there from cost to value and the healthcare impact to societal benefit overall. So thank you. We've probably got time for one question. Yes.
Alexandre Meja from EFM Teleton. We have been funding gene therapy for very severe neuromuscular diseases, and what we saw is that the ethical value has had a lot of weight in the acceptation for payment. What I mean is that it's easier to convince a decision maker to pay for a very expensive treatment when you say that the disease will kill a baby before 2, than to convince the same payer to pay for a very expensive treatment for a teenager who could, as you said, become someone with a job taking place in the economy. So that's very interesting because I got the feeling the decisions are made right now with completely opposite value as the one you proved.
I didn't, first of all, we didn't prove anything. I'm a biologist. Okay, stats doesn't prove anything. It just gives you something to work with. I didn't hear everything because unfortunately people were walking by, so I couldn't see your mouth moving, and I was only getting a bit of the sound. But in terms of that question of treatment of children and how does that get picked up in terms of economics, two different points there. There's a failing in the model here because of the 10-year time horizon, all right? A classic HTA analysis would allow a more extended time. These are different types of economic analysis. We will work on how you take that into account, because clearly if you have an effective therapeutic that returns a child to the workforce, to productive, and I'm speaking as an economist here, not as an ethicist, that is beneficial for society. Right? And there is a working assumption in the way that we run the model that death is not a cheap option, if you see what I mean. In other words, it gets discounted from the model. And therefore it's a question of how do you get value from an effective therapeutic that brings somebody into the workplace. So this approach would pick that up and encourage that kind of investment, provided that the outcome of the therapeutic intervention was to bring that person back into the workforce, into productive activity.
Okay, thank you, Matthew. I think I'm going to move us on now, but thank you very much. Fantastic talk.